Hi, my name is Saina Săndulache. I'm a medical oncology specialist registrar working at Portsmouth Hospital University Trust in United Kingdom, and I will be talking today about our pilot study, ARTA-ATTACK study, a project that I've been working on alongside my colleagues such as Professor Giuseppe Bana, Dr. Ben Smalley, Dr. Akash Maniam, and others. And I am pleased to share with you today our results. Like I've said, this is a pilot study, which is a prospective multi-center observational cohort study, and involved a data collection from two trusts, so Portsmouth, also known as Queen Alexandra Hospital, and Isle of Wight, UK, as well. We tried to look into the patients diagnosed with metastatic hormone-sensitive prostate cancer, the management of it, and the help we've received from the ONCOassist app, which was a great help to work with. And basically, management of prostate cancer commonly involves the androgen deprivation therapy combined with androgen receptor targeted agents, and we call these ADT and ARTAs. We looked at the patients, newly diagnosed patients that we've seen for the first time in our clinics, and we looked at the risk of sarcopenia, frailty, and neurocognitive impairment, which are some side effects that are sadly commonly seen in patients who are undergoing treatment with ADT. And also, these symptoms can often be exacerbated by the ARTAs. Knowing this, we still have limited data, prospective data, evaluating the impact of ARTAs on these conditions over time. So we tried to look at these patients, collect as much data as we could, and aim to demonstrate that these assessments can be readily incorporated alongside clinical practice without significantly impacting our clinical time. And of course, this is a pilot study, and we're aiming to propose for a larger study called ARTA-ATTACK. Our objectives were to develop and implement a tool on the ONCOassist platform to facilitate comprehensive geriatric assessment, to assess the time and the time impact and clinician experience of applying the ARTA-ATTACK protocol within our clinical practice on a day-to-day basis, but also to assess and report on all ARTA-ATTACK primary outcomes measures, including the G8 geriatric screening score, SARC-F, which is the Sarcopenia questionnaire, the muscle mass, the Mini-Cog, and the nutritional risk index, and others such as the Eastern Cooperative Oncology Group Performance Status score, the Charlson Comorbidity Index, IADL and ADL scores. It was interesting to look at the patients, and we are thankful for their participation in this study. There were a couple of inclusion criteria as well as exclusion criteria. So we looked at, of course, patients who were over 18 years old with a histologically confirmed hormone-sensitive prostate cancer, who have been started on ADT less than 6 months, and who were about to start monotherapy with ARTAs such as abiraterone, enzalutamide, apalutamide, or sometimes darolutamide. The exclusion criteria prior treatment with ARTA. So if they had treatment before, they had combination of chemotherapy with darolutamide, for example, then they will be excluded from the study. Or active central nervous system metastases, as well as contraindication to ARTA or significant comorbidities. And we had a few patients, of course, with significant comorbidities, the cardiac, past medical history, or others neurological history, or psychiatric past medical history. ONCOassist app saved our daily assessments by providing all of these scores, so G8, SARC-F, CCI, ECOG, performance status, ADL, Mini-Cog, and they're all very beautifully sorted out and then at hand in the app that we've been using each time we've been assessing this patient. We also looked at the body composition, and we assessed that. We assessed the muscle mass and fat mass at the beginning of the treatment. So consultation 1, but also we assessed the same patients at 3 monthly and 6 monthly, and these patients were a total of 47 patients. And we've seen some differences down the road. Basically, the results. So, like I've mentioned before, we did this study between May and December 2024, and we assessed 29 men commencing ARTAs across our two trusts. There were 48 comprehensive assessments with 30 patients assessed at baseline, 14 at 3 monthly follow-up, and I think there were 4 with a 6 monthly follow-up. And we try to combine these assessments with our clinical practice, which in our clinical practice we looked at body mass, fat mass, at the beginning, and then we carried on with the consultations. The results show that at 3 months there was an average of 1% decrease in this patient's muscle mass and a 2.36% increase in fat mass. Also 1.7 gram per liter decrease in albumin, and 1.46 points drop in the nutritional risk index. There was no significant change seen in any ARTA-ATTACK outcome domain in this time frame, but I remember discussing with the patients and with their relatives the impact this treatment would have on their daily activities. And even though the numbers may not seem as big, the significance of it has been seen in their daily lives. So we have in here in figure A the average time taken by each individual clinician to complete all the ARTA-ATTACK assessment within routine clinics. We could see that 33.3 of us managed to do so in between 5 to 10 minutes. 33.3 completed the assessment within 15 minutes, and the other 33.3 required 15 to 20 minutes assessment. And this it is important to keep an eye on, because these 15 to 20 minutes would be minutes allocated to the clinical practice, but would be an additional time to our clinical practice and the consultations that we are having with each patient every time we see them. We can see here the beautiful ONCOassist app on the right hand side, with a couple of the scores that we have used, and this figure B shows the ONCOassist mobile application and also the application interface and PDF exports for storage within patients' digital record, which is something that we've then later on looked into, and this is how we sort our data. Then the assessments were exportable into the Excel and spreadsheets for ease of data comparison. The conclusions. Use of technology does improve access to geriatric assessments without significantly increasing the consultation time. I would say that if we're managing to assess these patients within 5 to 10 minutes, then this is definitely true. For those of us who required a bit more time in assessing this patient, I think another person, being around and being ready to help is always useful, and it would be useful to have whether this could be a CNS or another member of the team, so we could speed up the process perhaps a little bit. The ONCOassist platform, it is indeed a valuable clinical tool for undertaking and recording these assessments, and I must say that we couldn't have done this without this platform. So thank you once again. This pilot study provides a positive feasibility assessment of proposed larger study, ARTA-ATTACK, to greatly inform both patients and clinicians of the nutritional, physical, and cognitive impact of ARTAs. And despite the short time frame of this feasibility study, there are demonstrable negative impact of ARTAs on nutritional and physical domains. And we've got their references with a shout out to all the colleagues involved and all the studies. We've kindly used to provide a better understanding and a better assessment. And a big thank you to my colleague, Dr. Smalley, and the participating patients who very kindly agreed to be assessed in this way, but also to the other clinicians and the ONCOassist platform developers for their support in conducting this study. Thank you ever so much, and thank you for being here today.